Welcome to Focus on Health, a series of educational programs highlighting current health issues sponsored by the School of Nursing at Salisbury University. I'm Dr. Mary DiBartolo, Professor of Nursing at Salisbury University and host of the program. I welcome back Dr. Jack Snitzer.
Thank you.
Thanks for coming in. You've been on the program before. You are an endocrinologist and you have a local practice in town, Peninsula Regional Endocrinology. And you are here to talk about a very common but important topic. We're going to focus on type 2 diabetes.
Right.
So I guess we should start by saying, give us an overview. There's a few types of diabetes, but we're going to focus on type 2 since that's the most common one.
Yes, yeah. Type 2 diabetes is by far the most common. About 90 to 95% of people with diabetes have type 2 diabetes. And that's caused by resistance to insulin, generally by being sedentary and overweight and genetics, where they can be on pills in the early stages, where type 1 diabetes is what we used to call juvenile diabetes, but age doesn't matter in any of these anymore. You can be any age and have any type of diabetes. Type 1 diabetes is caused by the pancreas being destroyed, the part of the pancreas that makes insulin being destroyed by the immune system, and these people have to be on insulin. Then there's some other fairly common to uncommon types of diabetes, like certain diseases called Cushing syndrome, where you make too much steroids in your pituitary gland or your adrenal gland, or if you're on steroids like prednisone, that can cause diabetes, or certain medications such as statins for cholesterol, they can actually raise the sugar. And same thing with some antipsychotic or psychiatric medications can cause type 2 diabetes or elevated blood sugars.
So what is the typical age that you may see type 2 diabetes though? It does tend to occur more so in the 30s or 40s, but that's lowering now because we're seeing more younger people developing type 2?
Yes, unfortunately. The typical age is probably 40s, 50s. It used to be 60s and 70s when I went into training and higher, but now I see preteens and teenagers, and it all depends on how their genetics are, how obese they are, and how sedentary they are, and what dietary patterns they have. Because about 10% of U.S. adults have diabetes. So that's about 30 million people in America that have diabetes, and we're probably underestimating that.
I know when I go to the hospital and take students, it seems like half the population has diabetes as their primary admission diagnosis, some complication, or a secondary medical diagnosis. So we know it's prevalent. And I know you also wanted to talk about prediabetes.
Prediabetes is very concerning because you can have prediabetes, which is defined by blood sugar numbers, but prediabetes is caused by the same things that cause type 2, but your blood sugar doesn't yet go up high enough to call it diabetes. So we call it prediabetes because we want the word diabetes to give it some emphasis so you won't ignore it just because the numbers aren't in the diabetic range. Because you can get all the complications of diabetes from prediabetes, and when you have prediabetes, we can do things earlier to prevent the development of diabetes. It's also called insulin resistance syndrome, where insulin doesn't work well, or another name for it is metabolic syndrome.
Okay.
And these people have no symptoms. That's the problem. That even the fasting blood sugar might be normal, but if you check their blood sugar 2 hours or any time after eating, the blood sugar might be high after eating, but not high fasting. So there might be no symptoms, and we want to catch it. Probably about half of people with diabetes or prediabetes have complications of diabetes when they're first told.
Now, what is the best way to diagnose diabetes, the official conversion to having type 2 diabetes?
And there's two ways of diagnosing prediabetes and diabetes. One is based on the A1C blood test, which is a 3-month sugar test. It just tells you what your sugars have been averaging for 3 months. And the other way is just based on the blood sugar. So prediabetes is an A1C between 5.6% and 6.4%, or a fasting blood sugar between 100 and 125.
And what's the normal blood sugar?
Normal, that's a good question. Normal blood sugar is, in somebody who doesn't have an inkling of diabetes, fasting should be below between 60 and 100, so basically 60 and 99, and the blood sugar never should be over 140. And so that's the other definition of, then you go into diabetes. The diabetes definition is an A1C 6.5% or higher, or a blood sugar fasting 126 or higher, or a blood sugar ever over 200 or higher.
My goodness, we know that's going on.
Yes.
Why we don't know? You said we don't really know exactly why it happens. Just that obesity, sedentary lifestyle, diet, all these things should be addressed if someone is looking to be pre-diabetic.
Right. Don't wait. Ask your family. Have I been at risk? Or just look in the mirror. If you're overweight, that puts you at risk. If you have high blood pressure, if you have high triglycerides, those are all risk factors for developing diabetes. And as I mentioned, certain medications can make it more likely to happen. So you just got to take care preventatively and not wait till you start feeling poorly. Because when the sugars start getting high, some of the first symptoms are you urinate more, you have blurred vision, you might unintentionally lose weight, you get tired, you just don't feel right, and you don't really know what's going on. But you don't feel terrible until far along in the course, probably about 8 to 10 years after developing diabetes. That's when people might start feeling poorly, and I'm talking about type 2 diabetes because it's a more slowly progressive disorder. Type 1 diabetes is a relatively quick progression, though.
Okay. Now, let's talk about some of the complications of why it's so important to keep an eye on this if you're pre-diabetic, have a healthy lifestyle, and then of course manage it well if you convert to type 2 diabetes. So what are some complications?
Right, and I would say that don't be afraid of being told you have diabetes because it's very treatable. A lot of people wouldn't go see the doctor because, oh my gosh, they're going to tell me I have diabetes and I'm just going to get complications. But complications are very avoidable. And the complications, the early ones, are what I mentioned, tiredness and blurred vision and higher risk of infections and unintentional weight loss. But the long-term complications, which can take 5+ years of having uncontrolled diabetes, and unfortunately some people get complications even with well-controlled diabetes, and we don't understand that. But most people it takes poorly controlled diabetes. But the complications are eye damage. It's a leading cause of adult blindness. Kidney damage. It's a leading cause of adult kidney failure and need for dialysis. Nerve damage, numbness, tingling, burning in the feet. It can be very mild to very severe. Get strokes, heart attacks. Those are diabetes is a major cause of death. The number one cause of death from diabetes is cardiovascular disease, stroke and heart attack. So you also have to treat your other risk factors. It's interesting that just lowering the blood sugar, making your diabetes better, number-wise, can help with eye damage and kidney damage and nerve damage, but it doesn't dramatically help with cutting down strokes and heart attacks. So you have to watch your blood pressure. You have to exercise cautiously because we don't want you to have heart disease and then just start exercising very heavily right from the get-go. And you got to control your cholesterol. And I mean, we're talking about very tight cholesterol and blood pressure goals for people with diabetes, much tighter goals than people who don't have diabetes.
Well, I guess all this comes down to getting your annual physical, once you reach a certain age, and seeing your healthcare provider and keeping track of these things, your blood pressure, your blood sugar, and so forth. And of course, not all diabetes has to be managed by an endocrinologist, a specialist like yourself. Right. So just remind our viewers the importance of just seeing their regular doctor, and then certain cases would then be referred to you as an endocrinologist.
That's very true. There's a scarcity of endocrinologists, so it's often hard to get in. As if you ever tried to get into my office, it's a lot better now, but when I was in solo practice, it could take 8 months to get in, and that's a nationwide thing, but it's improving. So we're trying to partially train the primary care doctors to be more comfortable with diabetes. But a lot of the primary care doctors can manage early diabetes, diabetes that's fairly well controlled on pills, and we often take over some of the control and care of the patients when they're on insulin or when they have lots of complications or when there's frustration or the patient doesn't have the knowledge base that they need. You have to try to participate in your own diabetes care, which means knowledge, education. And the PRMC Diabetes Education Department is wonderful. Everybody should attend the sessions, the group sessions there, and also medical nutrition therapy to learn how to eat, how to count carbs sometimes, because counting carbs and moderating the diet is everything. We're not talking about a deprivation diet. We don't want anyone to deprive themselves. It's a moderation diet. We want people to have things they like, which is totally different than when I trained. In the old diabetic diet 20 years ago was if you like it, you can't eat it. But nobody followed that, and it wasn't right. And now it's moderation. If it's not the best food, don't have it a lot and have it small amounts. But people need help changing their behavior, changing their lifestyles.
Right, that goes without saying with any kind of dietary change. You know, you don't call it a diet, you know, it has to be a lifestyle change and something that isn't totally punitive where you can't have
Right.
this or that. So it sounds like we have a lot of resources in the area to help people with that.
Yes, and family doctors enjoy it. It's time consuming, but family doctors enjoy taking care of diabetes because it's very rewarding. You can there's a lot we can do for it, and with diabetes management, as long as you'll get the most out of it if you participate in it, if you work with your family doctor, and if everybody's on the same page. I try to be positive when I talk to my patients who have diabetes, because they have enough negatives. I mean, they wake up and their sugar's high one day and then the sugar's normal the next day. It's so frustrating, so I try to look for any positive that I can to give them support.
Okay, so very good. So let's move on to the treatment, which is primarily medications to help control the blood sugar. And that's the key, keeping that blood sugar under control. That can help with some of the complications, as you mentioned. And there's 6 classes of medications. So I'll let you talk about each one of them briefly, as far as what exactly they do, that class of meds, the action, what are the common meds in that category, and so forth.
Sure. There's actually many more than 6 classes, but we don't use a lot of the drugs at all in some of the rarer classes of diabetes medication. But the starting drug for type 2 diabetes, and it's even starting to be used sometimes in pre-diabetes, is metformin. It used to be called glucophage. And metformin is a pill that you take once or twice a day, and how it works is it makes insulin work better in the muscle, so it tries to help insulin resistance, and it also tells the liver not to make too much sugar, because remember, there's 2 things that raise the sugar. Food is one thing, carbohydrates, but the other thing is the liver makes sugar. So why do people's sugars go up when they're stressed? Because the liver makes more sugar when you're under stress. So metformin is a drug that tries to tell the liver not to make so much sugar at the wrong time and in the wrong amounts. So the main side effects of and metformin doesn't cause low sugars, and it doesn't cause weight gain. It can even cause a 1 or 2 pound weight loss. And metformin also protects the pancreas. It keeps in people with diabetes, type 2 diabetes, the pancreas tends to burn out because it has to work so hard. So metformin, it sort of decompresses the pancreas so it doesn't have to work so hard, and then the pancreas doesn't burn out as fast. And the side effects of metformin would be things like nausea, diarrhea, especially at high doses, and if you're on high doses, it can also cause B12 deficiency. So we encourage taking it with food, and if you have any symptoms of B12 deficiency, like confusion or memory loss or difficulty walking, then the doctor can check a B12 level. And then
Yeah, go ahead.
the next class would be that we used to start after this, which is now we don't use as much, because even though it's cheap, there's only 2 cheap classes of drugs. Metformin is inexpensive, and the next one is called a sulfonylurea, which is very inexpensive.
They've been around for a long time.
They've been around, yes, probably 40 years, and we still have a lot of people on them, even though academically they're probably the worst class of drug we can use. What they do is they make you produce more insulin, so you can actually make extra insulin all day long. It's kind of almost overworking your pancreas to get extra insulin, because your pancreas is getting burned out and you can't make as much, so you try to stimulate your pancreas to make more insulin. Sulfonylureas have one major side effect. They have other side effects, but one major one, and that's low blood sugar.
Oh, goodness.
Which is probably one of the worst side effects you can have. Hypoglycemia, we call it, but you have to watch out for that. You have to use it very effectively. You have to eat regularly when you're on sulfonylureas, like glipizide.
Okay, I was going to say, what's some examples of those? I know for a while there, they were really some of the only drugs we had.
Right.
So
Glipizide and glimepiride, which is glucotrol and amaryl.
okay, but now we've moved on. There's many other newer classes of drugs.
Yes, and these are the drugs that are expensive, but they're, as all new drugs are, but there's all kinds of copay waiver cards and some vouchers you can get from your doctor, unless you have Medicare. Medicare doesn't allow discounts for medications. But one class of drug is called the DPP-4 inhibitor, such as Januvia. There's several others in that class, but it's a drug class that makes you produce more insulin, but it's kind of a smart drug. Januvia type drugs make you produce, and there's another one called Tradjenta, and there's others. They make you produce insulin, but only when you need to. So you take a pill once a day, and it makes your pancreas work only when your pancreas needs to work, such as when you're eating, when your sugar's high. So they don't cause weight gain, they don't cause low sugars. They don't affect the heart either. They're not good or bad for the heart. They're sort of neutral on the heart. A lot of drugs now we're picking because of other benefits. Like some classes of drugs for diabetes help the kidneys, some help the heart. So far the ones I've talked to are more neutral on the heart and the kidneys. Metformin might help the kidneys. Metformin might help the heart. There are some data recently that came out within the past week or two that says that show that metformin might have some benefit on the heart. But the next classes of drugs can help the heart more on the kidneys. For instance, there's something called SGLT2 inhibitor. There's Farxiga and Invokana and Jardiance. Those are the ones you're probably familiar with from TV.
Yeah. I think most people have heard of those. They're being pushed heavily on TV. So how do they work?
Well, when you read about the side effects, you won't want to be on them, but you have to remember, people tend to focus on side effects, and we tend to focus on, as physicians, the complications from the disease process itself. So we have to put the side effects in perspective. They work, the SGLT2 inhibitors make you actually produce or urinate out more sugar. So you urinate out sugar, and if you urinate out sugar, your sugars are going to drop. And also you're going to lose weight because sugar is calories. So if you urinate out sugar, you're going to lose weight.
So they're working mostly on the kidney then?
Yes, they make you they make you leak out sugar. So if you don't absorb the sugar, if it goes right through you, your sugar is definitely going to drop. So it can work in most people. And interestingly, some of these drugs show that they help the heart. They lower the risk of dying from heart attacks and strokes. Some of them also have evidence that they lower the risk of kidney damage from diabetes. So it's really kind of interesting. And the side effects of those could be dehydration because they make you urinate out sugar and water. They can also, some of them can lower the bone density, actually contribute to osteoporosis. They can cause urinary infections. And one of the most problematic, though, side effects of this class of drug is it can cause vaginal yeast infections or even yeast infections on the tip of the penis, which can be very problematic. Not too hard to treat, but it can be very problematic.
So I guess you have to outweigh, the benefits have to outweigh the potential for side effects.
Yes.
Not everyone gets the side effects.
Yeah, exactly.
But I guess it sounds like it's a very individualized plan of care
Right.
for that person based on their
Right.
complications and history. And I know you also want to talk about insulin. Of
Right.
course, that's a major drug used to control blood sugar.
And before we get to that, if you don't mind, one more thing about another class of drug that you see on TV all the time, the GLP-1 agonists, Ozempic and Trulicity and Victoza. Those are shots you take either once a week or once a day, depending on the shot. And there's Byetta and Bydureon. And what they do is they're shots that actually make you produce insulin only when you need to. And they also make you less hungry and more full. So most people lose a lot of weight on these agents, up to 15, maybe more pounds. And the benefit is some of them have data that show that they lower the risk of dying from cardiovascular disease. There's a lot of side effects you see about, but again, putting side effects in perspective compared to what does the disease itself cause, what problems does that cause. The side effects could be possibly pancreatitis. They list that there's a thyroid cancer called medullary thyroid cancer that might cause, but that's only been shown in animal models, never in humans. And these drugs, the GLP-1 agonists, have been out for many, many years.
Yeah, I've definitely heard of Byetta being, a nice drug that's often used.
That's from the Gila monster spit.
Right.
Yeah,
Now these are injectables, and now
Right.
we'll move on to insulin, which
Yes.
is also an injectable. So.
Yes. Insulin comes as either vials and syringes or pens. Most insurances allow patients to be on pens, which are really easy to carry around. You can put them in your pocket when you're going out for lunch. And there's two types of insulin, basically. There's a lot of insulins, but there's long-acting and short-acting insulin, or rapid-acting insulin. The long-acting insulin, such as Lantus or Basaglar or Tresiba or Levemir or Toujeo, those are insulins you take once a day generally. And what they do is they give you a baseline amount of insulin all day long in your bloodstream, the purpose of which is to fight the liver's production of sugar. In other words, to tell the liver to make the right amount of sugar. And so most people need some degree of long-acting insulin. But the problem with long-acting insulin is it tends to be overused at too high a dose in America. We're using it, we're falling back on it because it's an easy once-a-day drug, but it doesn't fight food. Long-acting insulin will not fight food. So what do we do to fight food? The answer is watch what you're eating, low carbs. Low carbs can smooth out the blood sugar more than I can do with medicine. Low carb diet, and I'm not talking about a terribly low carb diet, 180 grams of carbs a day, something much less than most Americans eat. But if that, and diet and exercise can help, and just staying active. But if that fails to control the blood sugar with meals, then we use rapid-acting insulin, and there's several of those. There's Novolog, Humalog, Apidra, and there's a new one called Fiasp. And these you give before one or more meals, and you take them right before you eat, or right after you eat, anytime from right before to right after you eat, and they actually counteract the food you're eating. Now, they're difficult, they're complicated because you have to give the right amount. You just can't give a random amount. So that's where the education comes in. We try to teach our patients, if you're eating more or eating less, or if your blood sugar is higher or lower, you take a little bit different dose of insulin. Not everybody can do that because it is a trial for people to learn that concept. But once they get the idea of, or the doctor trains them enough to adjust their insulin based on what they're eating and what their sugar is, they can do really well. And our goal, unlike the old days, our goal is to make these insulins fit into a person's lifestyle, healthy lifestyle,
Sure.
not vice versa. We don't want someone to turn themselves upside down so they can take insulin. Insulin can be kept at room temperature, can travel with you. It's very portable.
Now, many people do have to check their finger stick blood for what their reading is at certain times of the day. And of course, we've come a long way with that as well. There's alternative methods, correct?
Yes. And finger sticks are the old tried and true method. It's probably the most accurate. It measures the sugar in the blood. But it's really important to check the sugars some way. We'll talk about the sensors, because hypoglycemia, low blood sugars, is probably the most problematic side effect of diabetes in the short run. Complications like heart disease and strokes might kill people years or decades later, but low blood sugars can kill a person right away. If you have a low sugar in your sleep and don't recognize and don't wake up, you could have a seizure, you could pass away in your sleep, or during the day you could have a car accident because you pass out in your car from low sugar. So you have to use these things well, and you have to know what your sugar is. We've always thought of the finger stick blood sugars as primitive and prehistoric. We must have something better. I mean, they can send a man to the moon. Why can't they do something that doesn't require finger sticks? Well, now they can. There's 4 sensors out there that can check the blood sugar without doing finger sticks. The one you see on TV all the time is the Freestyle Libre, which is called a patch sensor. You put it on your arm, and it tells you what your sugar is when you swipe it. So you either swipe it with a reader or your phone, and it will tell you what your blood sugar is. And you change the sensor every 14 days. It stays on pretty well. It doesn't alarm, though. It doesn't tell you what your sugar is until you swipe it. So it won't tell you if you're dropping or if your sugar's rising. Then we have something called a Dexcom sensor. We have a new one called the Dexcom G6, which is a sensor you wear either on your arm or your belly. And you can leave it on for 10 days, and then you have to change it every 10 days. And these have little cannulas or wires that go under the skin that they monitor your blood sugar in interstitial fluid. So it's a little bit delayed. It's about a half an hour behind what the finger sticks might tell you. So you have to remember it's not right at the exact time. It's a little bit lagging. But the Dexcom G6 sensor, you don't have to calibrate, and as with the Freestyle, you don't have to do finger sticks much anymore, if at all. And the Dexcom actually can go to a reader if it's within 20 feet, or it can go to your cell phone, or it can go to up to 10 people's cell phones. So you can have your spouse, your children, or anyone you want receive your blood sugars every 5 minutes. So the Dexcom checks you every 5 minutes, automatically sends your readings to the cell phone, and you can program it to alarm if your sugars are getting too high or low, so it can wake you up or notify you before your sugar gets low. And then another sensor is called the MiniMed Guardian Connect, or the MiniMed Guardian, and that sensor is very good. Also, the same type of thing, although you still have to do a couple finger sticks a day with the Guardian. Then there's a new implantable sensor called the Eversense sensor. And the Eversense sensor, we actually make a little incision in the arm, put the sensor in, and we can leave it there for 90 days. And the new I'm sorry, we can leave it there. Yeah, for 3 months, and the new 6-month one is going to be coming out in the near future. So Europe has a 6-month one, but that requires just a little incision.
Sounds like we've come such a long way with diabetes management. I know there's no cure, but there certainly are much better ways now with both medications, sensors, and so forth, or monitoring the sugar to really keep people in that controlled state.
Yes, and it takes a team to do it. It's very time consuming, but well worth the effort.
Well, education is so important. And remind us again of the best way to prevent diabetes or to keep pre-diabetes at bay.
Well, if you know that you're at risk, go see the nutritionist. Join an exercise program. There's Core Life. There's all these exercise programs. But do some exercise. Learn better dietary skills. Watch not only the carbs, but watch high-calorie foods such as fats. Starches have to be minimized: breads, pastas, rices, potatoes, and of course the junky sugars: cakes,
Right.
candies, cookies, ice creams, pies, etc. Doing that, just maintaining a healthy lifestyle, not being so sedentary, and make it part of your fun, everyday being.
And of course, seeing your doctor on a regular basis to keep track of this kind of thing. It's so easy to check as the blood sugar or the hemoglobin A1C and get a feel if you're starting to head in that direction.
Yes, and the doctor, now we use A1Cs for screening too. So you can get an A1C blood test once a year just to screen you for pre-diabetes or diabetes, and your doctor gets at least once a year of regular blood sugar on you too.
And that doesn't measure your, like, right now glucose. That gives the doctor an idea how well it's been controlled over the past 3 months.
The A1C,
Right,
yes, the
or
A1C.
not. So that's a very excellent test.
Yes, it doesn't matter what you last ate. It will tell. It's not a lie detector or a truth detector test, but it tells us information that you can't get any other way just by doing one single blood sugar test.
Well, excellent. And thank you so much for being on the program. A lot of really important information for our viewers.
Oh, my pleasure, Mary. Thank you for having me.
And thank you for joining us for this edition of Focus on Health here on PAC 14.